Noswaith croeso. Good evening and welcome everyone. It's my enormous pleasure to be able to introduce Professor Sir Michael Marmot this evening. Professor Marmot has been Professor of Epidemiology at University College London since 1985. And for nearly 50 years, he has led groups researching health inequalities. He's author of The Health Gap, The Challenge of an Unequal World, that was published in 2015, and Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health, that came out in 2004. Professor Marmot is the advisor to the World Health Organization Director General on social determinants of health, and was a recipient of the WHO Global Hero Award in 2019. He is a distinguished visiting professor at Chinese University of Hong Kong and held the Harvard Lown Professorship for 2014 to 17. Amongst his many other awards, he received the Prince Mahidol Award for Public Health in 2015 and has accepted honorary doctorates from 18 different universities. At the request of Gordon Brown's government, he conducted the Strategic Review of Health Inequalities in England, which published its landmark report, Fair Society, Healthy Lives, in February 2010. And last year, he published a follow-up report, Health Equity in England, Marmot Review, 10 years on. He's an honorary fellow of the American College of Epidemiology, a fellow of the Academy of Medical Sciences, an honorary fellow of the British Academy, and an honorary fellow of the Faculty of Public Health of the Royal College of Physicians. In 2000, he was knighted by Her Majesty the Queen for services to epidemiology and the understanding of health inequalities. So Michael, it's marvelous that we have you here this evening. I'm very much looking forward to your presentation.
Thank you. Thank you very much. And you've given a nice introduction to what I want to talk about this evening. I've called my presentation, I gave it a different title when we set it up, but I've called it Build Back Fairer because that was the title of the report that we published in December. And I want to talk about that. But before I talk about that, I have to go back into ancient history. You mentioned my book, The Health Gap, and the opening line of my book was, why treat people and send them back to the conditions that made them sick? We think a great deal, particularly in the pandemic, with the load on the National Health Service about health care, but I want to talk about the conditions that make people sick. Slightly less ancient history is the report that I published in February 2020, Health Equity in England, the Marmot Review, 10 years on. Just to give you the background, I chaired the Commission of the World Health Organization on Social Determinants of Health, and we published our report in 2008, Closing the Gap in a Generation. Gordon Brown, then Prime Minister of the UK, asked me, could we apply the findings and recommendations of your global commission to one country, England? And so we set up an independent inquiry into inequalities in health, which we published in 2010 as Fair Society, Healthy Lives. The report that I did in February 2020 was a look back at what had happened in the last 10 years. And that's my summary. We've lost a decade and it shows. That's what I said back in February, before the pandemic. What do I mean? If we look at life expectancy in England, forgive me, but the report was about England, not Wales. But much of what I say to England about England applies to Wales. If we look at life expectancy going back to 1980, for females and males, it had been increasing about 1 year every 4 years. Pretty dramatic. In fact, if I went back to 1900, it had been increasing about 1 year every 4 years. So that increase that had gone on for more than 100 years, in 2010, slowed down dramatically, break in the curve, and it just about ground to a halt. The question is, what happened in 2010? Well, we know a new government was elected. Surely I couldn't be alleging that it was something the government did that could have led to this slowdown. Well, it's possible. I think we have to look at that question. One question that did get raised, particularly by people who were sensitive to the idea that maybe it was something the government did or didn't do, is, well, life expectancy can't keep increasing forever. Surely it has to slow down sometime. Well, I guess so, but we compared with other countries. So this was the annual life expectancy improvement in weeks between 2011 and 2017. UK is down there. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, Spain, all of these countries had a more rapid increase than did the UK. The only advanced countries that had a slower improvement in life expectancy were Iceland and the USA. So no, we had not reached peak life expectancy. The slowdown in the UK and in England was more marked than it was in all these other rich countries, except Iceland and the US. Inequalities in health can be described by looking at where people live and classifying where they live by degree of deprivation. And it's common to think of inequalities as poor health for the poor, that's life expectancy in the most deprived areas for men and for women, and good health for everybody else. But that's not an adequate description of what we find. In fact, it's a social gradient. The less the deprivation, the longer the life expectancy. It runs all the way from top to bottom of society. The inequalities follow the gradient. The gap between the least deprived 10% and the most deprived 10% was 9.5 years for males, 7.7 years for females. And that slope had been getting steeper. The gap had been getting bigger. And if we look at regional differences, this is women. For the least deprived 10%, it doesn't much matter which region of England you lived in. There were some, but relatively small regional differences, and life expectancy was improving a little bit for the least deprived 10% in all regions. Now look at the most deprived 10%. Life expectancy was going up in London, and it was going down for women in just about every region outside London. So just to summarize what I've said, in the decade from 2010, when I said we've lost a decade and it shows, the improvement in life expectancy as a measure of health for the whole population had slowed just about to a halt. Inequalities were increasing, both between socioeconomic groups and between regions. And life expectancy for the poorest people outside London was actually getting worse. That was our state in February this year. It was terrible. And we were falling behind other rich countries. And we shouldn't be thinking only about length of life, but quality of life. The top graph is the gradient in life expectancy, and the bottom graph is disability-free life expectancy. In other words, healthy life expectancy. And the gradient is steeper. It means that people at the top are living about 12 years of their lives with disability, and people at the bottom with shorter life expectancy are living about 20 years of their lives with disability. And this is state pension age, which the proposal is to advance it to 68. And you can see that 2/3 of people do not have disability-free life expectancy as long as 68, which means that if you advance the working age, you make people work longer, they're not going to be fit to work. They'll be on disability benefits rather than on a pension. Not a great social advance. And health, not just life expectancy, actually years spent in ill health have been going up. Health's been getting worse. Not a good situation. In my 2010 review, Fair Society, Healthy Lives, I had 6 domains of recommendations. People say, look, this inequalities in health thing is so complicated. What can you do about it? And my answer was, we've reviewed the evidence. This is what we can do about it. Give every child the best start in life, education and lifelong learning, create fair employment and good work for all. Number 4 was really radical. In a rich country such as the United Kingdom, everyone should have at least the minimum income necessary for a healthy life. Healthy and sustainable places in which to live and work, and what I call taking a social determinants approach to prevention. That's what we said in 2010. What happened? Well, the first thing, we didn't pay a lot of attention to the last one, healthy behaviors, for this reason. People are advised to eat well, the NHS Eatwell guide. If people in the most deprived 10% of households in England followed the healthy eating advice, they would spend 74% of household income on food. You've heard politicians say, oh, people don't follow advice. They only have themselves to blame. It's their fault that they're ill and unhealthy. No, it's not. It's not ignorance. It's not laziness. It's low pay. That's why people can't eat healthily. Our approach was, if you got the first 5 domains right, then the 6th one would be fine. Well, what happened? The government in 2010 said they wanted to roll back the state austerity, and they did. In 2009-10, 42% of gross domestic product went in public sector expenditure. And over the decade, that 42% by 2018-19 had gone down to 35%. They really did roll back the state. Austerity. And that austerity, that rolling back of the state, was done in a most regressive way. The grey bars here is total local authority spending per person by level of deprivation of the area. So if you look at the least deprived 20% of areas, local authority spending per person went down by 16%. And then the more deprived the area, the greater the reduction in spending, so that local authority spending per person in the most deprived areas went down by 32%. The greater the need, i.e. the greater the deprivation, the greater the reduction in spending. I showed this graph to an economist from the World Health Organization, and she said, "You're making this up." I've never seen anything quite as regressive as this. The greater the need, the greater the reduction in spending. Yep, we rolled back the state, and the more people needed money spent, the more we took it away. Could that have something to do with worsening health and increased inequalities? Yeah, I think it could. Look at adult social care. When adult social care spending went down by 3% per person in the least deprived, and by 16% per person in the most deprived. Now, this was all done notionally to get a better economy. Well, it failed, didn't work. This is wage growth from 2007 to 2018. And there's the UK, negative wage growth. The only countries that were slower, had bigger drops, were Greece and Mexico. Portugal and Italy did much like we did. And then every other country got an increase. So we practiced this austerity nonsense in order, we were told, to get a better economy. We didn't get a better economy, despite the lies that were told about it. And we caused damage. So I'm not going to go through all my recommendations, but let's look at child poverty. Child poverty is defined as less than 60% median income. In 2010-11, about 18% of children were in households in poverty, less than 60% median income. After housing costs, that was 27%, which I think is the more relevant figure. After housing, people have to pay housing costs. And that 27% went up to 30%. The Prime Minister in Parliament was asked about the rise in child poverty. He said, no, it's gone down. And he made some number up. It's gone down, he said. Well, it hadn't gone down, gone up. That's what the figures show. And if we look at family type, look at lone parent not working, 62% of children growing up in a household headed by a lone parent not working, 62% of children in those households were in poverty in 2010-11, and that went up to 70%, 2017-18. Work was supposed to be the way out of poverty. So let's look at a lone parent in full-time work. 18% of children were in poverty in 2010-11. That went up to 30% by 2017-18. That will damage children's development and will, of course, put stress on the parents. And then there were fiscal changes to the tax and benefit system. This is from May 2015 to June 2017. Let's look at working age families with children, this light green graph here, by deciles of income. If you were a family in the bottom 10% of household income, as a result of changes to the tax and benefit system, your income would go down by 15%. If you're in the second bottom decile, your income would go down by 12%, then by 9%, and so on. The richer you were, the less the reduction in income for families with children as a result of changes to the tax and benefit system. I sat with a former government minister and I showed him a version of this graph and said, your government's policy was to make poor people poorer. And he looked a bit uncomfortable. And he said, well, perhaps it was not our explicit policy. I said, they're very clever people in Her Majesty's Treasury. They must have informed the Chancellor that this would be the effect of his policies. And he did it anyway. And more families are spending more than 1/3 of their income on housing. 1996, 7, 2016, 7. So the most deprived about 38% of families are spending more than a third of their income on housing. Can you imagine if you're spending more than a third on housing and it would cost 74% of your income to eat healthily, that's now 110, 120% of your income. Who's going to pay for heating if you need to heat the house you're dwelling in winter? And heaven forbid, children would need a pair of new shoes. So housing is a food issue. Food is a poverty issue. Poverty is a housing issue. They're very closely linked. And then, perhaps related, the number of households in temporary accommodation increased dramatically. And the number of people sleeping rough in England tripled since the publication of the Marmot Review in 2010. This was reduced overnight with the first lockdown, but of course it's crept back up again. And with the cuts of services to young people, because of the cuts to funding for local authorities, what we see is, after a small dip, violence increased the most in the most deprived areas. Most deprived, least deprived, and this is violence going up. And you can see cuts to services, closure of Sure Start children's centres for young children, cuts to youth services, and then, oh my gosh, why have we got this epidemic of violence? Well, maybe it's linked to the cuts in services. And then there's, of course, pollution and the environment. The most deprived quintile, the least deprived quintile, PM10 is a measure of air pollution. The more deprived the area, the greater the exposure to air pollution in London, Liverpool, Birmingham, Bristol, Leeds, and Sheffield. And I very much want us to put the climate change agenda and the health equity agenda together. So, for example, in the February report, we said, ensure that 100% of new housing is carbon neutral by 2030, with an increased proportion being either affordable or in the social housing sector, and aim for net zero greenhouse gas emissions by 2030, ensuring inequalities do not widen as a result. So that was my report in February 2020. And then the pandemic crashed upon us. And I felt the need to do another report because of the pandemic. And we published this in December, and we called it Build Back Fairer, the COVID-19 Marmot Review, the pandemic, socioeconomic and health inequalities in England. We gave it that title, Build Back Fairer, not just Build Back Better, because, as I've already said, the status quo in February 2020 was not desirable. We shouldn't simply be trying to recreate where we were in February 2020. We should be trying to do something fairer. So what happened? If you look at mortality rates from all causes, there's the gradient in England, which is what I showed you a few moments ago. And there's COVID-19. It looks really very similar, the gradient. And the fact that the gradient in mortality from COVID-19 is parallel to the gradient in mortality from all causes means that the inequalities in COVID-19 mortality, the causes of it, are similar to the causes of inequalities in health more generally. So those 6 domains that I identified in my 2010 review are highly relevant. And then, in addition, some excess down here at the bottom for COVID-19 is related to employment in frontline occupations, living in overcrowded, perhaps multi-generational households, having to go to work in frontline occupations might mean going on public transport and being exposed to the virus. That was males, this is females, and it's the same picture. And then when we look at ethnic groups, these data come from the Office for National Statistics. Women compared to whites, this is Black African. They have nearly 3 times the mortality rate from COVID-19. And then asking how much of that excess could be attributed to geography, where people live, which is, as I've shown you, closely linked to deprivation, and quite a lot of it, and then other socioeconomic characteristics. So it means that a good part of this excess in women and in men is linked to deprivation, occupation as well. Interestingly, prior health status, lots of people, myself included, have been saying that having ill health puts you at higher risk of mortality from COVID-19. Interestingly, that did not explain the high mortality in Black African or in Black Caribbean. But it did explain some of the excess in Bangladeshi and Pakistani. So there's the excess in Pakistani, controlling for geography and other socioeconomic characteristics, and controlling for prior health status did make some contribution. Pakistani. One of the reasons that I use the term BAME reluctantly, Black, Asian, and minority ethnic groups, and I certainly tend not to talk about the BAME community because the groups are different and they have different health profiles. They all have an excess, but in the Indian, the excess is much less than it is in Black African and Black Caribbean. So they're somewhat different profiles. But what the pandemic exposed is inequalities in society quite generally, and in particular, as well as the socioeconomic inequalities, the inequalities by ethnic group. In trying to compare what's been happening in the UK with other countries, rather than look only at mortality from COVID-19, a better measure is excess mortality. In other words, you look at how many deaths you would have expected in 2020 if the rates of the previous 5 years had applied, and then how many did occur, and the difference is the excess. The excess mortality in England was higher than in Scotland and then in Wales. And in England, it was higher than in every other European country. People looking at the United States, and the president opted out completely from trying to manage the pandemic. It was an utter disaster. In the US, everyone's agreed. Our excess mortality in the UK is higher than in the United States. So if it's a disaster in the US, what does it say about what we've done? And let me remind you that pre-COVID, the slowdown in improvement in life expectancy was slower in the UK than in every other rich country, except Iceland and the US. And so I ask myself, what's the link? I think of health as a measure of societal success. And pre-pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. It means that society had stopped improving, inequalities in society were increasing, and social conditions for the worst off had got worse. And our slowdown in life expectancy was nearly the slowest of rich countries. And in the pandemic, we had the highest excess mortality. So I asked myself, what's the potential link between our poor health situation coming into the pandemic and our poor management of the pandemic? And I think the link could work in 4 ways: poor governance and political culture, social and economic inequalities increasing, reduction in spending on public services pre-pandemic. We were ill-prepared, and we were unhealthy coming into the pandemic. All of those potentially make the link between our poor state of health pre-pandemic and our poor management of the pandemic. Not good. And then we look at what lockdown did during the pandemic. So you remember my second recommendation was education and lifelong learning. Teachers were surveyed in the least deprived areas and the most deprived areas. In the least deprived areas, they said about 3% of their pupils were not behind at all. Just under a quarter were 1 month behind. A third were 2 months behind. In the most deprived areas, more than 10% were 6 months or more behind of the pupils, and 20% were 5 months or more behind. So you can see an increase in the educational divide. The more deprived areas, the kids were falling further behind. Less deprived areas, not so much. Food insecurity. It's been all over the newspapers in the last day or two about trying to get free school meals to those eligible. Pre-COVID-19, food insecurity, 3 or more children, households with 3 or more children went up sharply. With 2 children, it went up sharply. So food insecurity increased during the pandemic. Young females had higher rates of unhappiness or depression. 16 to 34-year-olds, percent of respondents with unhappiness or depression, that's males, it went up, and in females went up sharply. It went up somewhat in other age groups as well, but it's particularly the younger group, 16 to 34, in both genders, but more in women, unhappiness and depression. And the weekly number of calls for service for domestic incidents, domestic violence, this was 2019, and that's 2020. More calls for domestic incidents, victims of domestic violence. Unemployment wasn't quite as great as it might have been because of the furlough scheme, which was very welcome. But particularly for young people, unemployment is rising steeply and will rise further as the furlough scheme ends. So this is the highest unemployment, cumulative growth in thousands for young people. And unemployment rates increased in every English region between July-September 2019 and July-September 2020. So in the Northeast, where it was already high, it increased further. In London, increased further. West Midlands, East Midlands, etc. And of course, some sectors closed down. But it's not, in general, people with higher incomes who were in shutdown sectors. The lower the income, the greater the likelihood of being working in hospitality, retail sales, a sector that closed down. So it meant higher income people could continue working, perhaps from home. And what that meant, of course, is that higher income people didn't have the same opportunity to spend money, couldn't go to restaurants, couldn't go for foreign holidays. Why would you want to buy new clothes if you can't go out? So they probably spent less on clothes, less on hospitality, theatre and the like. Save money, wealth increased. Whereas the opposite was true at the other end of the scale. So an effect of the pandemic and closure was to redistribute income and wealth from poorer people to richer people. And percent paid below the national minimum wage by region in England, 2010 and 2020, 2010, 2020, not furloughed and furloughed. And one of the problems with the furlough scheme is it paid up to 80% of previous income, which means if you were below the minimum wage, being furloughed means you're still below the minimum wage. And percent who reported that their finances had been negatively affected as a result of COVID-19 containment, single adults, couples with dependent children, nearly 40% said their finances have been negatively affected. Now that will be more the lower the income, the more likely they are to be in shuttered sectors. So what did I recommend in my Build Back Fairer report? Well, remember, I said I think of health as a measure of societal success. And in the executive summary of the report, you can read our specific recommendations related to those domains: early child development, education, employment and working conditions, having enough money to live on, healthy and sustainable places to live and work. And those 5 will then allow people to eat more healthily, less likely to smoke, more likely to exercise and the like. But I want us to address these 4 issues that I highlighted as linking our poor state of health pre-pandemic with our poor state of health during the pandemic: poor governance and political culture, increasing social and economic inequalities, the reduction in spending on public services. We were ill prepared, and we need to be improving health. So my recommendation to government is put a fair distribution of health and well-being at the heart of all government policy. My specific recommendations say what you can do concretely, but put a fair distribution of health and well-being at the heart of all government policy as we build back fairer. Let me finish with this. Where might I have got this quote from? A well-being approach can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. That sounds like it could have come from philosopher and Nobel Prize-winning economist Amartya Sen. Yeah, might have. But no, it was from the New Zealand Ministry of Finance. They said in 2019, before the pandemic, they wanted to privilege not growth of gross domestic product, but well-being. And I would like us, as we emerge from the pandemic and build back fairer, to put at the heart of all government policy a well-being approach, which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Thank you.
Michael, thanks ever so much for that most powerful and sobering presentation. I'd now like to welcome participants to post questions on our Q&A link at the bottom of your screens to Michael. And whilst we're waiting for those questions to start coming in, Michael, perhaps I could start off by asking a couple myself. In terms of education, how do we go about repairing lost education for all these children?
I saw a figure last week and I need to chase it up, so forgive me for quoting someone else's figure without verifying it, but the figure was that the Eat Out to Help Out scheme cost the government about £850 million. For £850 million, you could buy a cheap computer for every child eligible for free school meals and get a subscription to broadband, £20 a month for a year. So instead of having a scheme last summer that promoted spread of the virus, for that same money, every child eligible for free school meals could have a computer and access to broadband. So that would be a good start. I didn't show you the data, but it's in my report. And it's obvious, but better off children are more likely to have access to computers and broadband. They're more likely to have parents with a bit of time to help them, more likely to have some privacy at home. And then particularly if they're in the independent school sector, what happens is 9 o'clock in the morning, they have maths, and 10 o'clock, they have French, and 11, they have a regular school day online. And that's not available to a lot of children in the state sector. So yeah, there's a great deal we could do. We could have prepared for this last summer and say it's urgent and high priority to get children back to school safely, instead of waiting till Christmas, New Year, and one day saying, perfectly safe, schools are perfectly safe. You can't catch it from schools, perfectly safe. And the next day saying, close the schools, close the schools. Well, I guess it's consistent. If there's no one in the school, it's true you can't catch it from the school, but that's not terribly helpful. Instead, we could have spent 6 months preparing, both making computers and broadband available to children and preparing schools to make it safer for teachers, for parents, and for pupils, for bubbles and the like, to go back in a safer way.
Thank you, Michael. So just trying to pick up some of the questions then. We had a question that came in early on this evening, Michael. Surely there's going to be a limit to how long we live. It's just the Eastern European countries had much lower life expectancy than the UK from the beginning, and they're now catching up. I saw Estonia, wasn't it, at the top of your list there? Could you address that for us?
Yeah, there are two parts to that. First, there are huge East-West differences across Europe. One of the reasons that I know, quote unquote, I never know anything, but I judge that communism didn't work European style in Central and Eastern Europe is because health, life expectancy fell behind that of Western Europe. It wasn't working. And in a way, the fact, if you agree with my general proposition that health's telling us something fundamental about the nature of society, it means society wasn't working for people in those populations. It's hardly a surprise that that was unsustainable. People wouldn't put up with it for forever, and they didn't. Now, what happened? Two things happened. One was health started improving again. The other was inequalities did increase in many of those countries. So dropping communism did allow things to get better, but it also allowed inequalities to increase. So that wasn't so good. So yes, they are catching up, but they in general have bigger inequalities in health than countries of Western Europe. The other side of it is it's not just length of life, but quality of life. And that's why I talked about disability-free life expectancy and the fact that the years spent in ill health has been increasing.
Okay, thank you. So a couple of questions relating to closer to home. Michael, do you believe that the Welsh Government has had a better approach to health inequality and the coronavirus pandemic? One of the solutions that has been suggested in Wales to reduce income inequality is a universal basic income. In your view, is there good evidence to support this?
Well, Wales in general has greater deprivation than much of England, so it's got a bigger challenge. That said, I've had a little bit to do with government in Wales, and I've been very impressed by the commitment from the First Minister and his colleagues, committed. When I met him when he was Minister of Health, and then I met him again when I came to Cardiff when he was First Minister, and there wasn't anything I could tell him that he didn't know about social determinants of health. He had a very good understanding about all of this. So I was impressed that there was deep understanding and real commitment to try and do something about it. But it's very difficult, and devolution only goes so far. And the disadvantage in Wales, the economic disadvantage, is quite marked. So yeah, I'm impressed with the Welsh Government, but there's only so much that they could do independently.
Why are governments not listening to these findings? Are they not held accountable?
It's interesting that my 2010 review was commissioned by the then government. My 2020 report was not commissioned by the government. It was actually sponsored by the Health Foundation, by a charity. And that's not right. The government should have done it. I would have been happy if they asked me to do it. Maybe they didn't trust me because I tell the truth. And you can't have people telling the truth, particularly if the truth is a bit inconvenient. So government should be doing it. They really should be doing it. That should be the way of them holding themselves to account. I mean, one of the questions that I do get asked, and it's a variant of the question you just asked me, is government listening? Is anyone listening? And one answer is, when we published our Build Back Fairer report on the 15th of December, on a Tuesday morning before Christmas, at 9 o'clock in the morning, we had a launch seminar, and 1,900 people tuned into that launch seminar. So government might not be listening, but people are listening. 215 participants this evening are listening. The second response is the national government in Westminster may not show much sign that they've been listening. I know the Welsh government has been, and regional governments and city governments in England have been. Greater Manchester, which has a population just about the same as Wales. I think Wales is 3 million, Greater Manchester is 2.8 million, 10 cities, said they want to be a Marmot region. Coventry is a Marmot city. We're working with Cheshire and Merseyside, Gateshead. There are cities and regions. As I say, I know the Welsh government has been listening. I've had several trips to Scotland at the invitation of the Scottish government. So it's not the case that no one's listening.
Excellent. Good to hear that. Has the disruption of the health visiting service contributed to health inequalities?
The easy answer is I don't know. I'm a big fan of health visiting, and I've spoken at the Health Visitors Annual Conference. They know that I like them, support what they do, but I don't know if it's the difficulties we've now had with health visiting. it's likely it's had an adverse impact, but I don't know of any evidence that shows that it has. But given that I think health visiting does a good thing, not having it is probably a bad thing. But I stick by my original answer. I just don't have the evidence.
Okay. A number of people have just said how fantastic the talk has been.
Yeah,
but question,
it's okay. You can read that out. I'm quite happy for you.
Having understood the role of the government and wider socioeconomic factors that seem to require both more funding and time to resolve, is there anything that the healthcare services themselves can do to tackle health inequalities in the meantime?
Yeah. We produced a report when I spent a year as president of the British Medical Association and then spent a year as president of the World Medical Association. And each time I produced a report on what doctors could do. And now the nurses have produced a report on what nurses can do. And we emphasized 5 things: education and training of the healthcare people. Second, seeing the patient in broader perspective. I showed you figures for homelessness. Do you treat a homeless person and throw him back onto the street? Not good practice of medicine, is it? Third, the health system as employer and more broadly as anchor institution having an impact on the local population. Fourth, working in partnership. And fifth, being advocates. And on the advocacy, the Royal College of Physicians set up an inequalities group. The Royal College of Physicians, they're hospital doctors, but they set up an inequalities group. And then they got together with some of the other medical Royal Colleges. When I published my report in February, they wrote an open letter to the Prime Minister urging him to act on the recommendations in my 10 years on report. Subsequently, they formed a Health Inequalities Alliance, which when they launched it in the autumn had 77 members. Now it's got 140 members. When they launched it in the autumn, I counted up, there were 20 whose name began with British, and 15, the name began with Royal, the Royal Colleges, and including nursing. And now there's 140. So yeah, there's a great deal that people working in the healthcare system can do along the lines of those 5 things that I just mentioned. And advocacy is a clear one.
Great. Michael, what do you feel has been the most detrimental part of the pandemic towards social equity?
I mean, the mismanagement of the pandemic has been the worst part, because if you look globally, the worse the mortality from COVID-19, the greater the economic hit. So our mismanagement of the pandemic from day one means that we've had to have these continued or repeated lockdowns, which means huge increase in social and economic inequalities. Had we managed it, I mean, Japan, their total number of deaths from COVID-19 is about the same as we've had in one day. Had we managed it well from the beginning, and we should look east to Japan, to Taiwan, to South Korea, to Hong Kong, had we managed it well, we wouldn't have had the big social and economic disruption, which means we wouldn't have had the big inequalities. So the biggest single failure is that failure of governance, of acting decisively. Remember what the Prime Minister of New Zealand said: let's act quickly and go hard. And what did we say? let's go slowly, let's dither, let's flirt with herd immunity, take it on the chin, said the Prime Minister, let it run through the population. It'll kill some people, maybe 400,000 people it'll kill, but then we'll be immune at the end of it. And then they realized maybe killing 400,000 people is not such a good look. Maybe we should do something. So we locked down too late. Oh, what about test, trace, and isolate? Well, we'll set up a testing system. No, let's scrap that. Let's not have any testing. We'll scrap testing, which we did in March. Oh, yeah, okay, let's do some testing. I've got some friends who manage large corporations. Let's give it to them. What about local public health? What about investing in local public health and give it to them rather than give it to your friends in large corporations? So it's a total mismanagement. It's a total governance failure. And that's what's led to the big inequalities.
Follow up on that, Michael. Someone said that, is there any chance of Professor Marmot applying for the position previously held by Dominic Cummings? How do you maintain your sanity when all your good work is ignored by the only people who can act on it? Perhaps you could elaborate a little bit more about, you mentioned these Marmot cities, regions. Could you just explain a bit more about that for us, please?
Well, in relation to Dominic Cummings, I don't even want to go to my local optician, let alone drive to Barnard Castle. I figure I got to make do with my current spectacles till the pandemic is over. I'm not going to go to an optician. And I'm certainly not going to drive to Barnard Castle to get my eyes tested. So I'm not applying for the Dominic Cummings role. I maintain my sanity, not just my sanity, but my optimism. Because when I chaired the WHO Commission on Social Determinants of Health, people said, what? Social determinants? What's that? Why have you chosen such an abstruse label that no one understands? What is all that about? I put on the cover of our report, social injustice is killing on a grand scale. People understood that. Social injustice is killing on a grand scale. We said in the report, inequities in power, money, and resources lead to inequities in the conditions of daily life, the conditions in which people are born, grow, live, work, and age. People understood that. And that in turn leads to health inequities. They understood that. And one of the members of my global commission, Dr. David Satcher, who was a former Surgeon General in the United States, he says, and he's one of the public health leaders in the US, he says that our global commission, our WHO commission, introduced the language of social determinants of health to the United States. Don Berwick, some of you will know the name, who's President Emeritus of the Institute of Health Improvement in Cambridge, Massachusetts, much admired advisor in Britain about quality of healthcare. And the Institute of Health Improvement is very much about quality of healthcare. He wrote to me and he said, Michael, your book, The Health Gap, I bought it 2 or 3 years ago, but I didn't get around to reading it till now, and I've read it. He gives an annual lecture to affiliates, 10,000 people or whatever, for the Institute of Health Improvement. And at his lecture a couple of years ago, he said, stop whatever you're doing. And if you don't want to listen to me, go out and buy and read The Health Gap. Because if you really want to improve the health of populations, pay attention to the social determinants of health. That's what you have to do now. So the language of social determinants of health has caught on in the US. Never mind Trump. when Obama was president, there was nothing happening at federal level, or not much, but a great deal happening at city level in the US. And we're working with Marmot cities and regions in England. I've talked about my good conversations with Wales and Scotland. I was invited to Trieste in Italy. I was told it was an Italian Marmot city. And I went. I was very impressed in what they were doing. Then I got another invitation to go to Bologna. I was told that was a Marmot city. And the penny dropped by now. And I said to the person who'd invited me, is it really a Marmot city, or did you just say that to get me there? He said, no, I just said that to get you there. But it doesn't matter. What they were doing was very much based on the same principles that I laid out. So we've got cities. I just wrote a paper with the vice president of Costa Rica. We've got cities, we've got countries, we've got regions who are acting on this. And if 1,900 people tune into a seminar at 9 o'clock on a Tuesday morning before Christmas, people are listening. And it won't be forever before national governments listen as well. So it's not just that I keep my sanity. I'm positively enthusiastic. I couldn't be more pleased. People are talking this language.
I think you could say the same thing about the over 200 people who've tuned in on a Thursday night in January as well.
Yeah, I could indeed. Thank you very much. You've encouraged my hopefulness.
Excellent. Perhaps one or two more questions. Do you believe that if the UK adopt a decentralised way of remote patient care management, it will result in reducing health inequities?
The prime cause of health inequity is not the way we manage the healthcare system. Most of it, as I said, the opening line of my book was the health gap was why treat people and send them back to the conditions that made them sick. The healthcare system is vitally important. When we get sick, we want good access to healthcare. And privatizing the healthcare system, particularly post-Brexit, if we sell it off to American corporations, that would be very bad. And having better regional and local management seems to me, other things equal, to be a good thing. But by and large, it's not the healthcare system that we have to pay attention to reduce inequalities in health.
Thank you. A couple of related questions. What can the general public do to help, and how can the average person help solve the inequality between the least and most deprived groups?
I think the quality of our society, the average person, is part of society. Look at what happened with the first lockdown. Wasn't it heartwarming? Wasn't it heartwarming? And I don't just mean going out at 8 o'clock on a Thursday night to clap for the NHS, although that was heartwarming. But people knocking on other people's doors and saying, can I help you? You know, to older people, could I help you with the shopping? Are there things I can do for you? And I think people were genuinely had a sense of social responsibility. I need to practice social distancing, not just to protect myself, but to protect other people. Somebody mentioned Dominic Cummings before. That sense of acting for the common good took a big blow when the government's chief advisor showed that he couldn't care less about acting for the common good and didn't get censured for doing it. I think it took a blow. So being a good citizen is something terribly important. You know, being part of a community, which is what happened with lockdown, certainly happened in New Zealand. People's account in New Zealand of what it was like, the real community commitment. The second thing is agitate for change, whether it's change at local government, regional government, national government. I try very hard not to be party political in public. And when people say, are you critical of the government? I'm not critical of the government because they're of a particular political party. I'm critical of the government if they're managing badly. The Prime Minister said he wants to level up. If you're serious about that, we can help you. We can show you what to do based on the evidence. But agitate to get change, to get better governance. So be a good citizen, look after your family, look after your community, get better local government, and be an advocate for change at national government level.
Michael, I think that's a really positive note to finish off on this evening. I'd just like to reiterate once again the number of comments that have come through to say how brilliant and inspirational people have found your presentation this evening. Again, many family and friends have indicated that they could listen to you all evening. So thanks once again for shining such a powerful light on highlighting disparities in health, not only in this evening's lecture, but for all the work that you've done over previous decades as well. So, diolch yn fawr iawn. Thank you very much again from all of us this evening.
My pleasure. Thank you.
I think my colleague Karen Edwards would just quickly like to come in to capture some feedback. Is that right, Karen?
Yeah, that's right.
Mike is going to share the screen.
If I can just hi. Hi.
Could you send me the comments, the Q&A?
Yes, Mike, can you save the comments from the Q&A, please?
Yes, sure, certainly.
Yeah,
certainly, I'll forward them on.
Okay. So, yeah, just wanted to add to James' comment, really. Thank you to Professor Marmot for a fascinating talk this evening. So if you wouldn't mind giving us some feedback, those of you that have been before will recognise this by now. But if you do have an opportunity to just answer a couple of questions, if you could go on to menti.com and use the code there 227357.6, and yeah, if you can. I see some people have started to access it. Thank you very much. It's great to see where people are joining from this evening. It's good to see we've got people outside Cardiff and outside Wales, even Europe and the rest of the world. Excellent. Okay, I'll just move on to the next question while people are sort of still catching up on the first question. So secondly, have you attended a public lecture with us before? Oh, it's great to see there's lots of new people this evening joining us that have not attended before. I hope you enjoyed, and hopefully we'll see you at further lectures that we run. Great. Okay, a few regular attenders as well. Okay, just moving on then. So where did you find out about this evening's lecture? So we've got our Science and Health webpage, university events page, Twitter. There's quite a lot of recommendations from colleagues, teachers. Hopefully we've had a lot of sixth form pupils joining us this evening. That's great. Thank you. Next, yeah, just wanted to find out why you attended the lecture this evening. If you could just give us the top 2 reasons for you joining. It's great you wanted to be informed and inspired, and hopefully I'm sure you will have been. Really good to know, thank you. And then as a result of viewing the lecture, will you be taking any further action? Has it inspired you? Has it improved your subject, your knowledge of the subject? Which most of you say that it has, which is great. It's really great to see that so many of you were actually inspired to do something different in your life. That's a pretty powerful message there. Great, fantastic. Okay, and then just finally, yes, give us 3 words to describe the lecture. I can see there that the popular words coming out: informative, inspiring, inspirational, insightful, fascinating. That's excellent. It's really good to have that feedback. Thank you for doing that for us. Okay, so while that's still chugging through, I'll just pass you back to James to give you some information about our next lecture, and thanks again.
Thanks, Karen. Yes, I'd just like to highlight that our next lecture will be on the 25th of February. It's going to be delivered by Dr. Anne Dixon from the Centre for Aging Better in London. And her talk is entitled Healthy Aging in the Time of COVID-19, How We Can Create Society Where We All Age Better. So hopefully we might see many of you back again next month. So once again, many thanks for your attendance this evening. Stay safe, everyone, and hopefully we'll see you again next month. Nos da, diolch yn fawr iawn.